The next speaker is also from the UK, and that's Dr. Jared Wong. Most of us know him from the bone workshops, as he has been doing a lot of work on bone health in Duchenne. And today he will be there to speak a little bit more about what's happening in adults and what should we know about this management. So thank you for being there again, Jared, and the floor is yours.
Right. Thanks very much, Elizabeth, and to the organizing committee for asking me to share with you some of the aspects of endocrine and bone management, but specifically in adults with Duchenne muscular dystrophy. Some disclaimer, as you might see from the slide, and Elizabeth may have mentioned, that I am a pediatric endocrinologist. My major interest is in endocrine, but also bone health in children and young people, specifically in the DMD population. In Glasgow and certainly with myself, patients are generally seen under my care till their early 20s before moving on to an adult specialist that we have recently identified in the last 3 years with an interest in this population. As with a lot of aspects of today's talk, there's very little evidence in this area. I will discuss the pediatric international standards of care, highlight some issues in terms of how we extrapolate that to the adult population, perhaps give you more questions than answers, and also highlight the need perhaps to develop some more detailed adult-centric management, particularly drug therapy pathways in adults with DMD. So next slide, please. So as Ross probably would have discussed at the start of the meeting, and I apologize, I was unable to join at that time, the adult DMD population is very heterogeneous, as we have different people with different types of health conditions, but also specifically with treatment protocols. So this next aspect is an important aspect, but relates really just to men with DMD, adult men with DMD, who continue to be on steroids from childhood till adulthood. And it's the matter of adrenal insufficiency. So if you are not treated with steroids or have discontinued steroids a long time ago, this is not a matter that needs to be of concern. So I just kind of want to make that, because sometimes that confuses people. Next slide, please. We know that steroid medicines like prednisolone and deflazacort, which are generally used, are very good for a whole range of health outcomes, as has been discussed. These are artificial form of steroids, and the body naturally makes steroids from two glands that sits on top of the kidneys called adrenal glands. But when steroid medicines are taken for more than a month, i.e. as a treatment, like in Duchenne, this switches off this master regulator produced by the gland here called the pituitary gland, called the ACTH. ACTH normally tells the body's adrenal gland to make natural steroid hormones, or called cortisol. But when any of us take steroid medicines like prednisolone or deflazacort for generally more than a month, it switches off this signal. It then tells the adrenal glands to go to sleep, so to speak, and does not produce any more of the natural steroid hormone or cortisol in the body. If this happens, this condition is called adrenal insufficiency. You might hear your doctor say adrenal suppression. Sometimes to some of my patients or children particularly, I say that the adrenal glands have gone to a deep sleep. When there is adrenal insufficiency, the critical point to mention is that during times of illness or significant stress, extra steroids needs to be given, as this is what generally happens in life to cope with the stress, to fight the infection. Next slide, please. So in severe instances, when a man with DMD is critically unwell, for instance, with severe COVID, for instance, much more steroids is needed. And that's because if it's not given, the person can tip into what we call an adrenal crisis. Now, I appreciate that we sometimes don't tell patients the symptoms they look out for, which might suggest adrenal crisis in the context of an illness or stress. The common symptoms include severe headaches. They feel lightheaded or faint. Obviously, in a young boy who is still walking, feel faint when they're standing, or in a man with DMD, for instance, when they're sort of like trying to sit up. They're very drowsy and tired. Usually, and quite often, they can be vomiting or really bad upset tummy with no particular reason. Or in fact, a tummy bug could also be a trigger of adrenal crisis. So these are some things kind of to look out for. Now, to the medical doctors on the call, one needs to remember that in the context of adrenal insufficiency, where particularly in primary adrenal insufficiency, where the defect is in the adrenal gland itself, we see typical electrolyte abnormalities with low sodium and high potassium. But please note that in the case of adrenal insufficiency due to a switch centrally, you do not see low sodium and high potassium. So please don't wait for that kind of abnormalities in a man or a boy with DMD. You just won't see that. So critically, in the event of vomiting illness or very severe illness, for instance, severe COVID or any other infections where the young man is very tired, lethargic, management of adrenal crisis or impending adrenal crisis is important. And in those instances, oral steroids is not an option because one, they're either too well or in fact, they're vomiting. So the updated International Standards of Care into 2018 highlights this important point. And ideally, families should be equipped with intramuscular steroids in the form of hydrocortisone, where either the family or the attending emergency staff can inject prior to presentation to hospital. They need to be seen in the hospital urgently. And in the hospital, management with steroids into the veins, intravenous, should be instituted. Obviously, adrenal insufficiency is also seen in a whole lot of other conditions, and it might be within your hospital or in your country or in your region. There are specific protocol for management of adrenal insufficiency, but if you're in a country or a site where doctors are unaware of adrenal insufficiency, please, of course, refer them to the PJ Nicholas steroid protocol, which can be identified through various patient websites, for instance. Next slide, please. In the instance of mild illness without vomiting, we now believe that extra oral steroids on top of the treatment dose of the Deflazacort and prednisolone may actually be needed to prevent adrenal crisis. And it might actually be more of a problem in boys who are on or men with Deflazacort. We do know that the treatment dose of prednisolone and Deflazacort used in DMD will cause adrenal insufficiency, but it is possible that these doses do not last long enough to cope with stress of an illness over a 24-hour period, particularly with the Deflazacort. Increasingly, although not covered by specifically in the standards of care, I believe that lots of hospital sites and countries are now recommending the use of either giving the prednisolone or the Deflazacort a few times a day, or what a lot of us are doing, certainly at least in the UK, is to ask for oral steroids in the form of hydrocortisone tablets, just like the injections, but in the form of tablets, to be given 3 to 4 times a day on top of the usual prednisolone or the Deflazacort, if there's, I guess, milder illness without vomiting, where the young person is still reasonably well. I put vamorolone here, which might be less of an issue in the adult population, at least in the short-term period. We know that this might make the clinic, at least for pediatric patients in the coming years, and perhaps this is also something that will make the adult clinic in the future. And of course, we don't really know how vamorolone is useful as a stress dose, and therefore an oral stress dose regimen is very important, and hopefully will be addressed in the pediatric clinic first already. Next slide, please. So in terms of hospital management of adrenal crisis or during surgery, for instance, because the young person can't take any steroids by mouth, there are obviously different regimens, but again, I can refer medical doctors or patients to the PJ Nicholas protocol again. Steroids, an IV bolus of steroids should be given, and then this can be continued either with ongoing 4 times a day of bolus of steroids to the drip or continuous infusion. Sometimes at the presentation of severe illness or adrenal crisis, blood sugar level is low, and an IV dextrose bolus may be needed. Next slide, please. So one matter might be more of an issue, at least in some clinics with of men with DMD. Obviously, there seems to be a push or increased trend to continue steroids in adulthood, but on some occasions when steroids are to be discontinued, one needs to remember that this needs to be weaned and specific tests needs to be done to ensure that the adrenal axis is normal. So clearly, if this is to be done, this should not be done. So steroids should not be stopped abruptly. So for the patients in the call, this should not be done. You need to consult with your local clinician and also perhaps some discussion with the endocrinologist. My approach for the clinicians in the call is that I tend to wean the therapeutic dose of prednisolone and deflazacort over a couple of months, and then convert to oral hydrocortisone at physiological replacement for 6 to 8 weeks, and then I perform a synactin test. Remember, the greatest risk of adrenal crisis is during discontinuation of steroids because they are on much lower dose of steroid cover, and with any illness trigger, a stress dose is clearly needed, and the families need to be educated well on sick day dosing. Next slide, please. So remember, mild viral illness with a fever and oral stress dosing is needed. Do think of also bisphosphonate infusion, perhaps less of an issue in adults. This seems to be commoner for illness and fever and vomiting with first dose. Often this will already be started in pediatrics. Specific painful dental procedures, also have to think about that. And clearly, if there needs to be any dental procedures done under general anesthetic, the dentist should be aware of the risk of adrenal crisis if you're on long-term steroids. Next slide, please. So let's talk about bone next, which again, increasingly we recognize that the bone morbidity is high, particularly with the use of steroids and daily steroids. There's still a lot that we don't know about the fracture morbidity in adults with DMD. We looked at our clinic experience and found that fractures are higher in those who continue on steroids, which makes sense, and maybe less so in those who are not on steroids. There are clearly a lot of things that we still need to learn in health aspects of adults with DMD. There is also a lot of variability in management of adults with DMD. Some clinics are more inclined to stop steroids in adulthood. Some continue steroids. Some actually lower dose of steroids, although continue at a lower dose in following loss of ambulation or in adulthood. And I think these are factors which may impact on some of these health outcomes like bone, which not all is related to steroids, but is a large part of it is due to the steroids. So next slide, please. So we know that low trauma fractures are very common in boys and men with DMD. We know that at least 50% of these boys will have a fracture. And in younger boys, long bone fracture may cause early loss of ambulation. But particularly with steroids, we also recognize that vertebral fractures or spine compression fractures of the backbones are very common and underestimated if diagnosed just based on presentation of back pain. Spine compression fractures, particularly in a non-ambulant boy or an older boy, even if the pain is not severe, does cause a whole lot of bother because if you're sitting in the chair the whole time, mild back pain due to fractures can actually impact a lot on your quality of life and also cares in the family. Next slide, please. I'll come back to the international standards of care and also what we do with vertebral fractures or spine compression fractures in a bit. But the next thing to actually also be aware, and for the clinicians in the room, is that fat is the issue of fat embolism syndrome, which has been described in boys and also adult men with DMD following a fracture of the long bones or sometimes just with a fall. And these are usually with fracture femur. And unfortunately, some have actually led to poor outcomes. We believe that this is due to the increased amount of fat in the bone marrow of long bones in boys with DMD. With a trigger of a fall or a fracture, these excess fat in the bone marrow then travels into the bloodstream and circulates to the lungs, the brain, sometimes to the kidneys, and also to the skin. And typically, fat embolism syndrome presents after a few days, usually 2 to 3 days after a fall or a fracture. Sometimes the fall can be fairly trivial, but if there's breathing issues, neurological abnormalities by the boy or young person feeling quite drowsy for no particular reasons, and there are rashes potentially sometimes where it sort of purple rashes that doesn't go away, almost like the meningitis rash, the consideration of fat embolism syndrome needs to be given. This needs to be raised with the treating doctor and managed aggressively, but of course, there's no specific treatment for that. It's all with supportive oxygen, ventilation, and all the other stuff, depending on what the patient presents with. But clearly, of course, there are issues about the amount of oxygen that may need to be given, particularly in an adult man with DMD. Next slide, please. So what does the updated standards of care talks about in boys and men with DMD? All boys, particularly those who are on steroids, should receive vitamin D supplementation. Annual blood monitoring of vitamin D is useful. The 2018 standards of care suggest that lateral spine imaging or X-rays should be done to identify vertebral fractures at the earliest possibility rather than waiting for it to present with severe back pain. However, I must say this is sometimes not always very easy to be performed in an older man with DMD. So in some patients, particularly also those who've had metal due to scoliosis, interpretation of these images are actually extremely challenging. But if there's new or unusual or severe back pain, I think the clinician needs to be contacted. One other issue as well also relates to the fact that sometimes even an X-ray picture doesn't give, X-ray image does not give you a good enough image to identify or diagnose vertebral fracture. Clearly, for the clinicians, if the clinical presentation suggests a vertebral fracture and if the X-ray images are not particularly good, other forms of modality of imaging is needed, like a CT or an MRI. A bone density scan is recommended, but I would say prioritize the lateral spine imaging where possible. There are a whole host of challenges and difficulty in acquisition of the bone density scan, interpreting it and what it actually means. And there still needs to be some consensus of how we proceed in the adult population. Next slide, please. So the treatment algorithm of osteoporosis in DMD is that we use intravenous bisphosphonate or bone strengthening medicines that stop the breakdowns of bone with the first low trauma fracture. And these include vertebral fractures identified on these lateral spine X-rays, even without back pain, if it's of the moderate or severe category. We don't treat mild vertebral fractures without back pain as yet. I think this needs to be adjusted, and we are hoping to get some funding to actually look at it in a research setting and also get the opinion of clinicians and patients. So bisphosphonate therapy, there's now a good randomized trial in Duchenne, which shows that it stabilizes bone density, it stabilizes vertebral fractures, and but although it may be less effective for the reduction of long bone fracture. If it's commenced in the pediatric range, previously most centers will stop it after a few years, but we now recognize that the osteoporosis in DMD, especially in the context of high-dose steroids, is very aggressive. We tend to continue therapy into adulthood. There are, of course, some concerns about the use of long-term bisphosphonate therapy. And occasionally, after at least about 10 years of using these medicines, we may actually take a bit of a holiday over a year or two and recommencing after a while. In adulthood, there's the choice of other medicines which can stop bone breakdown. But there are also other more excellent drugs that can be used for osteoporosis in DMD, which is drugs that actually build bones, which we can't actually use in children because of certain contraindication, or it's never been tested. And these will come into play, and I'm sure there are maybe some patients, adult patients, who are on it already. But what do we do if you've got fractures that started in adulthood where there's not been in pediatrics? I think this is where we need greater consensus on when do we treat the first fracture in adult, which medicine to use. And in the UK, we're hoping to, within the North Star network, together with Ross and MD UK, develop some more UK-specific adult bone management. And you might ask, why develop UK-specific guidance? Because there are some specific country by country specific regulations of which drugs can be accessed. But hopefully, if we do develop this, this could be useful for other countries as well. Next slide, please. So let's talk about puberty and also testicular function. Next slide, please. Very briefly, most boys with DMD on daily steroids simply do not start puberty. And therefore, the recent updated standards of care recommend that testosterone therapy to start puberty for these adolescent boys is useful. And we now have good evidence that it actually does its job. It helps with some growth. There may also be some bone and muscle effect, basically, certainly some bone effect. Next slide, please. Generally, my protocol is to start with testosterone therapy, and increasingly I start at a much younger age, about 12 to 13. So these boys are much more matched to their peers rather than waiting till the age of 14 or 15. I treat these adolescents with testosterone over a 2 to 3 year period, mimicking physiological puberty. I stop testosterone when they reach adult size maturation, but then I want to also test to see if their testes are functioning and making enough testosterone by themselves. And the good news is, and this is a small cohort that we're hoping to write up in time, is that the majority also seem to have good development of their testes and also good levels of male hormones or testosterone level as adults. But there are a small number of men with DMD who still do not make testosterone levels, adequate testosterone level, and need testosterone supplementation all throughout their life. And this is something that I think in time we will also learn a little bit more. And I suspect this relates perhaps to actually the steroid regimen and treatment. Testes make male hormones or testosterone. The testes also have cells which actually influence fertility. This is an aspect which I guess many years, maybe 10, 15 years ago, we think that this is not important at all in this population. But of course, we know that just because you've got a physical disability doesn't mean that fertility is not an important matter at all. There is practically little information on this aspect in the published literature. Anecdotally, we know that there are some men with DMD who have become fathers. But I think it's important for us to try to find out and tease out this aspect of whether there are actually problems, but also whether fertility is actually an issue that matters to young men with men with DMD in general. And we can then develop guidance on how we can actually approach this subject or manage this in time. Next slide, please. So this is my last slide. And really just to summarize some of the things that I've talked about, that adrenal insufficiency for patients on long-term steroid requires sick day planned and also alerts to be put in the hospital. Bone monitoring, it needs to be individualized in men with DMD, as there are some technical challenges of imaging the spine or even doing bone density. But if there's a new pattern of back pain, which is severe or unusual, imaging of the spine is needed, and we may need to think of other modalities other than X-ray if the X-ray is not sufficient. A small number of men with DMD may need testosterone treatment due to hypogonadism or not making enough testosterone. Fertility is an issue that we don't really know, but clearly perhaps monitoring of gonadal function at testosterone level in men on long-term steroids is recommended, but we don't have the clear evidence of that. I think next slide, please. Last thing is that there are just a couple of symposiums that that clinicians perhaps will be interested in. They're targeted at clinicians. The first is probably more pediatric centric, the online symposium. The second is a more adult centric symposium. So please do circulate it to other people who are interested. And thank you very much and happy to take questions.